Good evening, one and all. Today's topic is my favorite, bone marrow pathology, an approach to the interpretation with some case studies. So let me straight away go with the how to approach a bone marrow. Now, any lab investigation, we should remember that it starts with, though we are not clinicians, so-called clinicians, it has to start with the history and clinical findings. And then comes the basic lab investigations, a knowledge of the normal hematopoiesis, bone marrow aspiration, cytology, biopsy, and that will be completed, the diagnosis will be completed only with the supporting investigations for final interpretation, which will include cytochemistry, special states, ISA flow, conventional karyotyping, fish, and now in the modern era, molecular analysis. Now with basic information and history, I mean history of presentation of the patient, the age, sex of the patient, whatever is presenting complex like anemia or cytopenias, whether lymphadenopathy, hepatosplenomegaly. Bone marrow, invariably we do it for hematological malignancies or infections or staging purposes. So based on the request of the bone marrow examination, we will have to look at the history and collect the relevant history. Now, the first and foremost will be the CTC, because without the histograms, scattergrams, all these values which you get from the instrument are meaningless. So we have to make it a routine practice to view the histograms and scattergrams, because a lot of cases can be diagnosed even at this stage. Though this is outside of the purview of today's talk, I would reiterate that this is the most important thing one pathologist can do before touching the bone marrow slide, right? Now, next comes the peripheral smear. Peripheral smear, correlate the counts and see what your impression about the peripheral smear is. Another important test in hematological conditions will be a retic count, which is a very simple test but gives a lot of information, and relevant biochemical investigations. Now, though iron studies and vitamin B12, we don't do a bone marrow for nutritional anemias, still these will help in many conditions. Then apart from that, the LFT, KFT, electrophoresis, Rbcs, lymph node or any other tissue biopsy will be very useful. Sample time for bone marrow interpretation. So routinely we get the EDTA and heparin, EDTA for morphology and flow cytometry, heparin for the cytogenetics. Now in the bone marrow that is aspirated, so there are different types of smears which can be made. The particle smears, which are made similar to a peripheral smear. But this is a very useful smear according to me, because the spread of the cells is much better than particle crush smears, which has crush artifacts and bare nuclei which you cannot interpret. Third one is the imprint smears. Now these imprint smears give you a lot of information, especially when it is a hemodiluted aspirate, because so many times even a metastatic deposit or a cluster of blasts sitting at the edge of the imprint will be very useful. And last one is the bone marrow biopsy, which Dr. Sanjay will deal with in great detail. Once you start microscopy, so what are the steps in which we look at the bone marrow aspirate? First one will be a scanner view. Whenever it is a hematology slide, whether it is a peripheral smear or a bone marrow, I see people directly putting a drop of oil and start visualizing all the cells in detail. That is not the way. I would want to make it very, I would like to stress that a scanner power and a low power view will give you a lot of information, especially when it comes to bone marrow. You can assess the cellularity, the megakaryocytes with adequate, or even the morphological, if there is dysbiosis, you can look at it at this power itself. Metastatic deposits can be identified at a scanner view, which you might miss if you directly go to a high power or a oil immersion. High power, yes, good for morphology and doing a differential count. However, if it is a very cellular smear, then you would like to go to oil power and then do the differential count. You assess the ME ratio at this stage. And oil immersion, of course, for the final morphological details, then other parasites like KFP, LD bodies, etc. And this differential counter, I still am comfortable with the differential counter, but I see my students now using the mobile phone to do a differential count. I'm yet to learn that. Coming to the cellularity, As we all know, 100 minus the age in years. Suppose a 10-year-old child comes, so 100 minus 10 is 90. 90% cellularity you can expect on a bone marrow. You look at both the particle cellularity as well as the cell trace. Because, for example, if you look at myelofibrosis, the particles may be cellular, but because of the fibrosis, the cell trace will be empty. So this gives you additional information in interpretation. Then you look at them and say whether it is hypercellular, hypocellular, if the fat spaces are more and the cells are less on the cell trails, then you call it a hypocellular or a normocellular. This you will learn only by experience, but cellularity definitely is best assessed by a bone marrow biopsy. When you go to differential count, be methodical, be systematic. Look at all the cells, do a good 500 cell DC for a bone marrow to get the correct myelogram or the differential count. And of course, the different stage, cell count will be based on the age of the patient. Because in children, a 30% lymphocyte would be normal, whereas in adults, it is abnormal. One should know the stages of hematopoiesis, how it develops from the stem cell. You have the myeloid progenitor lymphoid, myeloid getting into erythroid, myeloid, as well as the megakaryocytic series, whereas the lymphoid will give rise to your B and T lymphocytes, which go to the lymph node and mature into the plasma cells, right? And in the myeloid, again, you have the 5 different types of cells: neutrophils, eosinophils, basophils, monocytes, and the basophils. Coming to erythropoiesis, you have different stages of erythropoiesis. So you have these large pronormoblasts with hyperbasophilic cytoplasm. As they mature to the early basophilic or the intermediate cells, and then you have these late normoblasts. Subsequently, the nucleus gets extruded from it. You get the polychromatophilic cells or the reticulocytes, and then you have the mature Rbcs. These are the stages in the erythropoiesis. And you always look at erythropoiesis, they live together, they live in the company of each other. And this is called an erythroid island, where the macrophage is in the center surrounded by the erythrocytes. They want to take up the iron in it for the production of hemoglobin. Coming to abnormalities, you can either have micronormoblastic or megaloblastic maturation. But when it is dyserythropoiesis, you will have multinucleation of the RBCs, or you can have nuclear lobated nuclei, or even nuclear budding. These are the features of dyserythropoiesis. Myelopoiesis, we all know: myeloblasts, promyelocytes, myelocytes, metamyelocytes, band forms, and the neutrophils. So if you look at these myeloid cell series, so you have lesser number of immature cells, the blasts. Then you have some pronormoblasts, promyelocytes here. Then comes your myelocyte stage. Then the metamyelocyte stage, band forms, and the neutrophils. So these are the different stages in the myelopoiesis. This myelopoiesis, you will have either nuclear image abnormality or the granular abnormality. And in thrombopoiesis, you have the promegakaryoblast, megakaryoblast, which is increased nucleocytoplasmic ratio, but you identify them because of this cytoplasmic plaques and from where the platelets are arising. This is a mature megakaryocyte with a proper hyperlobated nucleus. This megakaryopoiesis, you can see it in the form of binucleation, multinucleation, or hypernucleated megakaryocytes. Now, lymphopoiesis, not much in the bone marrow, but you should identify how the lymphoblasts look and how they are different from the myeloid blasts. Monocytopoiesis, only 3 stages. The monoblast will have a very thin rim of cytoplasm, but identify them by the nuclear contour, whereas promonocytes are much larger, more abundant cytoplasm, and thin lacy chromatin. Lacy chromatin is the feature of promonocytes. These are the mature monocytes with cytoplasmic vacuolation. Other than that, you get the macrophages. So you identify them by the frayed cytoplasm and the debris here. Then you also have the sea blue histiocytes or the pseudo-Gaucher cells. Other cells in the bone marrow, sorry about that picture, but this was a picture of osteoblasts, which are similar to plasma cells, but more basophilic cytoplasm, and they are in clusters. This is an osteoclast, mast cells. The stromal changes you will see with Dr. Sanjay Pai. Iron stores, then you have to report. So you need at least 7 particles before you can label them as decreased iron stores. But now with iron studies done in a biochemistry lab, you rarely rely on this. Anyway, you should be aware of the grading of the iron stores, and also you should be aware of the cydroblasts. So now cydroblasts are those normoblasts with 1 or 2 pinprick cydrotic granules. Whereas 1 to 5 coarse granules, it becomes an abnormal cydroblast, and ring cydroblast if there are more than 5 granules in the perinuclear ring. This comes in helpful in MDS diagnosis. Once you look at all these, then you have a proper reporting format. So you mention the clinical diagnosis, microscopy. In microscopy, you talk about the particle cellularity ME ratio, a differential count done on 500 cells, and then talk about the details of the morphology of erythroid myeloid megakaryocytes, talk about the lymphocytes and plasma cells, histiocytes, any abnormal cells. Do not forget to look at parasites and granulomas as per the indication, Pearl stain to comment on the iron stores, then 2 simple cytochemical stains which you can use, PAS and MPO, and these can help you in the preliminary diagnosis of an acute leukemia. And then once you inform the result, a panic result to the clinician, please make a note. This is good for documentation. And other than that, you can have other cytochemical stains for leukemias as well as lymphomas like TRAP. Then you have your oil red O and other special stains for the fungal and parasites. Immunophenotyping is the next step. So detection of abnormal cells, lineage assessment, then MRD analysis, you get the prognostic markers and to know about the targeted therapy. Cytogenetics, conventional, again for diagnosis, prognosis, monitoring the treatment, and for certain AMLs where the cutoff of 20% is no more required, then you need the conventional cytogenetics to call it a leukemia. Molecular genetics, now with WHO 2016 itself, you see everything is diagnosis is based on the molecular studies, which can be done by either fish or the DNA analysis or the TCR gene receptor rearrangements, etc. So to conclude my session on the normal interpretation, I think these are the basic things you need: a peripheral smear, retic, the different types of bone marrow aspirate smears, iron stain, that is by Pearl stain, MPO, PAS. So you can give a good diagnosis with only this much material. But once again, I would like to tell you that your diagnosis starts with the CBC, especially in aplastic anemia, megaloblastic anemia, leukemias, MDS, CMML. At this stage itself, by looking at your scatter plots, the numbers, and also something called as the research population data, which is in a lot of papers are there now. Start looking at them routinely. So you know, suppose for example, here the lymphocyte is large. If it is a small, maybe pointing towards an aplastic anemia. Look at the scatter plots. Now this is a case of, it's saying monoblast, but it may be a reactive lymphocyte as in dengue. So all these things help you a lot in making a diagnosis. Over to you, Dr. Sanjay, for that.
I'll be talking about the trephine. And until 2006, most of us used to botch up our bone marrow trephine biopsies because we used to treat it like any other biopsy, treat it, put it into formalin, then put it into acid, and then put it into the processing machine. And that was it. And really, we didn't get good stains. But in 2006, my good friend, Professor Naresh, who was at Hammersmith then, published a paper in the October 2006 paper of Journal of Clinical Pathology of what they call the Hammersmith Protocol. And you guys should read the paper in detail in JCP, but essentially they put a bone marrow into something called the AZF solution immediately and leave it to fix overnight. And after overnight fixation, the solution is discarded and the biopsy is washed in distilled water, then decalcified and then processed. And that gives excellent stains, excellent sections, which can be stained very well. Immunohistochemistry also comes out very well on it. It doesn't get over decalcified or under decalcified. And molecular tests can also be done on the trephine biopsies. So I strongly recommend that if there's nothing else that you're going to learn from this lecture, this is the one thing you must learn. Learn to process your bone marrow trephines in the Hammersmith protocol. You always are going to perform the HAD, of course, to look at your cases. But beyond that, do make it a point to do a reticulum stain on 100% of your cases. If ever by mistake I sign out a bone marrow on just an HAD, I get a call from my angry hematologist saying, what's the bone marrow reticulum stain report? I need to have that too. And I'll come to why that is important. From time to time, of course, we need to do a Z-Nielsen if there are granulomas. Matter to do a PAS or a mucicarmine if you suspect a fungal infection. And although I put pearl stain for iron out there, the fact is I don't remember having ever done a pearl stain for iron, because pearl stain is done by the hematopathologist who does the aspirate and reports on it. The second problem with the hematopathologist who looks at the aspirate is able to give a good opinion on pearl stain. Beyond that, there is the problem that if you process a bone marrow through formalin, iron gets leached in it, and therefore your pearl stain is never going to give you very, very good results. And so it's probably not required at all. And finally, immunohistochemistry is of useful in many cases in tumors as well as in non-tumors. And I'll elaborate on that sometime in the future, the near future. Now, Dr. Jain did warn you that I have a great interest in history of medicine, and the answer to your question, Dr. Jain, is I'm interested in history of all sorts. But yes, history of science and history of medicine is my greatest area of interest. But it will interest you guys to know, at least I hope it will interest you guys to know, that it was Newman and Bizzozero who in 1868 independently showed that the bone marrow was the site of blood tissue formation. From there to 1876 was only 8 years before Mosler decided to perform the first aspirate and look at what these cells looked like. Because of the technical problems involved in performing a trephine, it took almost 65 or 70 years for the first trephine biopsy to be done, and that was in 1943. Why, of course, do you perform a biopsy when you can do a very, very good aspirate and opine on it? And the fact that you could opine on aspirates for 60 or 70 years without doing trephines. The reason is, well, there's a much longer list if you look at your textbooks on why you do trephine biopsy, the indications for trephine biopsies, as you call it. But very briefly, you do it for increase or for decrease in blood cell counts. You do it if there's an abnormal smear, peripheral smear, that is. Very importantly, you'll do a trephine biopsy for pyrexia of unknown origin, which is not at all an uncommon problem in our country. You do it for staging and for progress of therapy, especially cancer therapy. And then you do a bone marrow trephine if you want to collect material for special studies. That might be stuff like immunohistochemistry or molecular biology and the like. The minimum size of your trephine biopsy should be 1 centimeter. Why is that? Because when you are going to be looking at it under the microscope, you will be ignoring the first 2 spaces of subcortical bone, because that is going to be entirely fatty. So if you perform a biopsy which is just half a centimeter long and has, let us say, 3 spaces under the microscope, if you're going to ignore the 2 spaces, all you're going to get is 1 space to give an opinion on, which is not enough. And you're going to miss out on a lot of regions, either which are focal or which are diffuse when you have just 1 or 2 spaces. And so your bare minimum should be 1 centimeter. Just as when you talk about a liver biopsy and you talk about, or even a kidney biopsy, how you determine what a minimum tissue should be for a trephine bone marrow biopsy, it should be at least 1 centimeter long. The components of the trephine biopsy. Now, Jayashree has already told you what you see in an aspirate. In a trephine biopsy, you look at the bony trabeculae with osteoblasts and osteoclasts. You look at the stroma, the collapsed sinusoids, blood vessels, reticulin fibers, fat. And interestingly, I forgot to mention out the most important thing, the hematopoietic cells. I mean, I've taken it for granted, and so I forgot to put it out here. The fat to cell ratio, Jayashree has already described to you in the aspirate, and it is roughly the same even in a trephine biopsy. It is practically 0 to 100 at birth, 10 to 90 at 10 years, and then as age increases, the fat increases and cell goes down. And it is roughly half and half, let us say, at the age of 50. That gives you an idea. Do remember that when most of us look at bone marrow biopsies, we tend to focus or concentrate on the hematopoietic tissue. And that is an error because the first thing which I mentioned out here is bony trabeculae, and bony trabeculae are also something that you should look at. The components of this stroma are the vasculature and the stroma, and that's important because conditions such as serous fat atrophy, vasculitis, amyloidosis are things that you will make a diagnosis only if you pay attention to the stroma, and you will miss it if you look only at the hematopoietic tissue. If you don't look at the bony trabeculae, you would miss a potential diagnosis of a Paget's disease or an osteosclerosis, even an osteodystrophy or osteoporosis. And some of these conditions we have seen and made in bone marrow biopsies, and they were unsuspected. This, of course, is what a normal refined bone marrow biopsy looks like. And I don't know where I've taken this biopsy or who the biopsy is from, but I would guess that this is an approximately 50-year-old patient, judging by the fact that this is half fat and half hematopoietic tissue. And of course, all of this is the hematopoietic tissue, and the blue stuff in between are the hematopoietic cells. This red out here is probably due to surgical trauma. It's just RBCs. A higher power of the same thing showing normal bony trabeculae, and take a look at the thickness of the normal bony trabeculae. Of course, depending on what angle you cut it at, you are going to get slight variations in the size and shape and thickness, but this is roughly the thickness of a bony trabecula in the bone marrow. The rest of it is fat and hematopoietic tissue, and like I said, it's roughly half and half at this age. And here is a case where you would see that the bony trabecula is a little irregular and much thicker than it was in the previous section. There's a reason for it. It's not been placed at an angle and cut. It's thick because this is an osteoblastic lesion. And if you look at it, there is an adenocarcinoma out here in the bone marrow. This is normal marrow, but this is tumor. You can see little glands out here. So this is an adenocarcinoma metastatic to the bone marrow. And this was an osteoblastic lesion, and therefore there is a much thicker bony trabecula than is normal. Erythroid series cells are what you would see in the bone marrow, and they are seen largely in the central region of the marrow. If they are paratrabecular, by and large, they are abnormal. CD71 immunostain helps pick up erythroid series cells if you're not sure about what a particular cell or particular series of cells is. And this is what a CD71 would stain like. Okay, and you can see this is the bony trabecula and it's in the center. Again, a higher power of a CD71 immunostain showing erythroid cells. Very often you don't need a CD71, you can figure out on HAD. This has just been done for the sake of teaching. Whereas myeloid series cells are seen along or kissing the endosteal surface of the bony trabecula and trabeculae, and they are myeloperoxidase positive. And here we are, MPO positive cells which are along the bony trabecula, kissing it like I said, and they are positive for this. You can see these are erythroid series cells which are away from the bony trabeculae. And you can see even with this stain, you can see that this looks like an ink spot nucleus. What you are taught in right from first Rbcs about ink spot nuclei being the hallmark of erythroid series cells. Megakaryocytes, the third kind of cells, are uniformly distributed and are central. If in groups or paratrabecular, they are usually abnormal. Megakaryoblast and micromegakaryocytes are difficult to identify on HAD. In fact, probably even impossible to identify on HAD. And that's why you often need to do a CD61 immunostain to pick up micromegakaryocytes and megakaryoblast. Else you might call something on normal bone marrow and miss the increase in micromegakaryocytes. Occasionally, megakaryocytes show emperipoiesis. That is nothing abnormal. It's part of normal. And here is what a CD61 stain would show you. This you can identify is a megakaryocyte, and it's being stained. And these are single cells in the interstitium, and hence these are normal megakaryocytes. Again, a CD61 picks up what you would not have recognized on HND as a megakaryocyte, and that's because these are micromegakaryocytes. Here's a normal megakaryocyte, here's a normal megakaryocyte, but these you would have missed had you not done the immunostain. Lymphocytes, on the other hand, are inconspicuous and blend in with the rest of the marrow. If there are aggregates, they may be benign or neoplastic. Aggregates are likely neoplastic if monotonous, or if they are paratrabecular, or if they are over 3 in number, if there are no germinal centers, or if they have irregular margins in a biopsy, and of course if they are BCL2 positive. Plasma cells from 3 to 6% of the cells are CD138 positive and are CD20 negative. You do a reticulum stain, and on 100% of your biopsies, I repeat, 100% of your biopsies, and grade it from 0, which is no fibers, which is normal, to 4, which is coarse fibers and collagenization. Do note here, I've written for grade 1, occasional fibers is often normal. That's because I spoke to my hematologist yesterday and asked him how he interprets grade 1s. And he said, if you report a grade 1, that's occasional fibers in a case like an ITP, he says, I'm going to ignore it. It doesn't make a difference to my management. But if you report a grade 1 in a case where I'm suspecting myelofibrosis, it becomes of great importance. That is the reason he expects us to do a reticulum in all cases. You never know when you're going to pick up something. That's a grade 3 fibrosis. And some rules, aspirate pathology is almost always seen in the trephine, but not vice versa. Something which I should have told you earlier, carcinoma breast may be invisible in a bone marrow trephine biopsy. Always do a cytokeratin immunostain, even if the marrow looks normal. Amyloid may be missed in the case of multiple myeloma. Always perform a Congo raid. And yes, would you believe it if I told you that this is purely by chance that I got this image? I dropped this trephine while I was about to put this into a cassette, and I realized it looked like a smiley. So I took this photograph some years ago in the hope that I would be able to use it sometime. And indeed, here we are able to use it. So this smiley is accidentally prepared and is a bone marrow. We now go on to the cases. I'll take some cases and then Jayashree will go on to the other half. So case number 1 is a 67-year-old woman who's a known case of CA esophagus. She presented with pancytopenia. She had no liver, spleen, or nodes. Now, when a bone marrow biopsy is performed by a hematologist in a patient who has presented with pancytopenia when she has CA esophagus or any carcinoma, he's got 2 questions in mind. One is it metastatic carcinoma? And the second is, and you'll see what the second question is. Okay, she really had pancytopenia. She had no abnormal cells on smear, and her counts were 8.9, 2,500, and 12,000. And the aspirate, as you can see, is largely fatty. All these are just fat, and there are very little to no particles. Again, no particles, just fat. A third example of just fat, nothing else. This is the same smear. We do the trephine. Now remember, this lady was 67 years old, so you'd expect something like a 30% cellularity or 25 to 40%, let us say, cellularity in a normal trephine. And this is clearly not that. All of this is fat. And here is a little bit of blue, which is marrow. Again, 2 more cores in this patient showing just fat, nothing else. Just fat, nothing else in this marrow. And this blood is due to the procedure, the RBCs that is. And here finally, you have some hematopoietic cells. And most of these, even at this mag, you can see are erythroid series cells because you can see the ink spot nucleus. I can't see any megakaryocytes out here. And you remember that the platelet count was only 12,000. Again, largely erythroid series cells and a lot of fat. And even in this area, which has got hematopoietic cells, you find 50% or more than 50% of the marrow is just fat. Okay, this is just to re-emphasize what I just told you. Ink spot nuclei, erythroid series cells, and fat. And our diagnosis was aplastic anemia. No great shakes, very easy to make the diagnosis. And in this case particularly, it was easy to make, but it is crucial not to jump to the diagnosis of aplastic anemia in every case where you see fat and very few hematopoietic cells. That's because you have to differentiate aplastic from hypocellular AML and from hypocellular MDS, because both of these are obviously diseases which are malignant or pre-malignant and have entirely different connotations from the point of view of treatment and prognosis. Both of these diagnoses are made essentially on aspirate and require careful examination. If there's any doubt, you might want to do a CD34 on the trephine biopsy to pick up blasts. And finally, cytogenetics. If the hematologist has a suspicion before he goes in that he or she might be dealing with either an AML or an MDS or an aplastic, he or she would be sending the tissue for cytogenetics. This is important, and I can confirm this with my hematologist colleague yesterday. All adults with aplastic anemia should be screened for PNH because there exists something called PNH aplastic anemia overlap syndrome. And apparently, we've had 2 patients of paroxysmal nocturnal hemoglobinuria in the last 7 or 8 years of guys who had aplastic anemia with PNH. So it's not just in the textbooks, it happens in real life. Just some theoretical bumps about aplastic. You get progressive cytopenias and marrow aplasia. When you do an aspirate, you get a dry tap, which you have just seen, and the biopsy must contain less than 25% of the normal cellularity at that age, which we satisfied just now. CD34 cells are substantially reduced if it is done. Do note that subcortical hypoplasia is physiological from beyond the age of 30, and I did tell you that you must ignore the first 2 spaces. Remember that. So you are going to look at it beyond that. If there is only fat in the first 8 intratrabecular spaces or largely fat, you can make a diagnosis of aplastic anemia. If there is less than 8 spaces, intratrabecular spaces which contain fat, do not rush into a diagnosis of aplastic anemia. Discuss the case with your hematologist. And although I did tell you in the beginning that you need at least 1 centimeter to make a diagnosis of a core, to make a diagnosis of aplastic anemia, you ideally require a 2 centimeter long bony core because you have to be very, very sure that there are no hematopoietic cells elsewhere. Aplastic anemia is now considered a T-cell mediated destruction of stem cells. That's just some theory for you. And you know that it's idiopathic or can be linked to ionizing radiation or drugs and chemicals and multiple other things. So we'll end with one more slide. The most famous victim of aplastic anemia that we all know, and that's Marie Curie, who died of aplastic anemia because of her exposure to ionizing radiation, for which she got 2 Nobel Prizes. The next case is a 51-year-old chappie with high-grade fever for 1 week, cough with expectoration, weight loss. He was admitted and deteriorated in hospital. Then the impression was he had tuberculous meningitis. He had cytopenias and he had homogeneous opacities on chest X-ray. And here is a bone marrow aspirate which shows a normal cellularity. Forgive me for this bubble out here, but this is a normal cellularity. Again, normal to maybe even mildly hypercellular bone marrow, but there's nothing else. Here's a megakaryocyte. In fact, there are 4 megakaryocytes out here. So nothing else out here of import. Again, normal to mildly hypercellular bone marrow with nothing of significance. But when you go to the trephine, you see something entirely different. All of this looks normal, but here is what almost any of you guys would be able to identify as an epithelioid granuloma, an oval epithelioid granuloma, which here is non-caseating. This is a higher part of the same thing, epithelioid histiocytes, and no caseation. So we call this a granulomatous lesion consistent with mycobacterial infection. This was AFB positive, though I didn't get the AFB image out here. This was AFB positive, so we call it tuberculosis. But do remember that in a bone marrow biopsy or anywhere else, a granuloma does not always mean tuberculosis. There are multiple causes for having granulomas. They could be bacterial, fungal, viral. They could be drugs such as NSAIDs, Hodgkin and non-Hodgkin's, autoimmune disease, sarcoid. Yes, the entire index of the textbook, it looks like, can be thrown at you and say, can cause granulomas. But that's the problem. You have to figure out what it is. And I have to apologize for this. I cannot remember the story behind this bone marrow. I saw this many years ago. And I happily took a photograph and saved it, and now I can't remember the story. But this was a bone marrow that I saw a granuloma in, and you can see the epithelial histiocytes. There's no doubt that these are epithelial histiocytes, and it's forming a granuloma. And incidentally, what's the definition of granuloma? The British Society of Gastroenterology defines a granuloma as a granuloma is that which happens when 5 epithelial histiocytes get together. Okay, so they say 1, 2, 3, and 4 can come together by accident, but when a 5th one comes together, it forms a granuloma. I don't know of any equivalent definition of the bone marrow or lymph node or anywhere else, but I adopt the same definition for all organs now. So this was obviously a granuloma, but it didn't look like TB to me, and I told the physician it's not TB. And for some reason, I suggested EBV or toxoplasma, and it did turn out to be one of the two. I don't remember the story behind this now, unfortunately. And here is something, a liver, in which I saw this granuloma with this fat space in between. This is a liver, I repeat, not a bone marrow. I'm not saying this is the bone marrow, but I call this probably Q fever. And in Q fever, which is caused by Coxiella burnetii, you get a fat space in the center surrounded by some fibrin and a granuloma. So this is probably a fibrin ring granuloma, in my opinion. After our final diagnosis, this was a tubercular granulomas. The next case is an HIV positive 50-year-old chappie who came with nausea, abdominal pain, headache, giddiness. He was an anti-tubercular therapy, but he had a liver spleen with splenic abscess, abdominal nodes, and effusion. The full Monty. And CBC showed pancytopenia, and CD4 was obviously low because of HIV. And here's the aspirate, which looks fairly normal in both of them. Again, this looks fairly normal, but when you look at this higher part, you can see something out here, and it's difficult for me to figure out at this stage or at this mag what we're looking at. But here, it should be obvious even to you that we are looking at yeast forms. So these are lymphocytes, obviously, these are RBCs, and these are yeast forms of what? The yeast forms stained pink with PAS stain. So with periodic acid shift, it's positive. It's positive with GMS also, and now you see so many of them. We didn't see too many of them on the HND, and we are seeing so many of them out here. And we grew Cryptococcus neoformans on culture. It was also antigen positive. And this is apparently what a colony looks like. My microbiologist colleague gave me this. Oh, sorry, here's the trephine where you can see there's something going on out here, but it's difficult to figure out what. The rest of this is normal hematopoietic cells. And here again, if you look, yes, here is something. These are obviously not RBCs because these are what RBCs look like. These are RBCs, these are lymphocytes, and here are those yeast cells. The PS on the yeast cells shows there are many more of them than you would have suspected on the HND, and we call this Cryptococcus in the bone marrow and confirm with all these stains. In HIV, you have opportunistic infections such as, I think this is spelled wrongly, yes, such as tuberculosis, Cryptococcus, histoplasma, leishmania, and so on. And Cryptococcus is a common opportunistic infection, but it is rare in the bone marrow. It may or may not form granulomas in the bone marrow. And remember, if it forms granulomas, it explains my previous statement that if you see a granuloma in the bone marrow, do not jump to the conclusion it is tuberculosis. However, the number of cryptococci is inversely proportional to the granulomatous response. And in our case, there were no granulomas, but there were a lot of cryptococci. And occasionally, cryptococci in the bone marrow have been reported as a presenting feature of HIV. Okay, this is an interesting case. A 49-year-old chappie referred in view of low hemoglobin, was a renal transplant patient on therapy. And really, this history alone should give you a clue or should suggest to you that you should be looking for a particular thing. This is what Dr. Jain and Jayashree referred to when they said that clinical history is very important. You must keep this in mind, as I'm assuming you have done for the previous cases too. And here is the bone marrow aspirate, which is, well, nothing much in this. Again, just some fat out here, nothing much. Okay, at this magnification, actually, it looks like you can't see much, but because I know what the diagnosis is, I noticed that there's something going on out here. Cells which are slightly bigger than I would have expected them to be, and they're not megakaryocytes, mind you. Again, you can see something out here. So you can suspect it on scanner or look. And on the higher power, here we are. What has got blue cytoplasm is therefore normoblast or pro-normoblast, and which have got prominent nucleoli or inclusions. Again, the same. And now there are many of them, and we can't miss them, and they stand out in this crowd. You can see that the blue cytoplasm tells you it's an erythroid series cell. Again, this is clearly an erythroid series cell. These are pro-normoblasts. And on a trephine at a low mag, you can't see anything. But on a higher magnification, you can see this cell. One more here, and a prominent nucleolus. Higher power shows 3 of them out here, one more here, one here, one here. There are quite a few of them now, actually. You can't miss this. And because it is big, you shouldn't jump to the conclusion that it's cancer, because it just doesn't look like cancer. And there's abundant cytoplasm out here. When you do an immunostain for parvovirus B19, it lights up. All the cells light up. And like I said, this was the clue. When a patient with renal transplant turns up, you must keep parvovirus B19 always in mind. And it's in giant pro-normoblasts. And immunohistochemistry is confirmatory. These patients present with cytopenias, usually anemia, but we're present with hepatitis, myocarditis, or pneumonitis. There can be dysfunction or allograft loss in 10% of cases. And so this is a diagnosis you cannot afford to miss. If picked up early, IV immunoglobulin is the treatment of choice and will save the graft. The next case is a 9-month-old girl with developmental decay, a recent viral fever and persistent thrombocytopenia, as you can see, 25,000, and a liver and a spleen. And the clinical diagnosis was, and this is very important, because this is why the procedure was done, acute ITP because of platelet count had dropped, or hypersplenism, or disease related such as Gaucher's disease. And this is a normal aspirate, and here we can see something. Okay. Again, you can see these cells which have clear cytoplasm. Clear cytoplasm again in these cells. Clear cytoplasm, large macrophages, what is called, well, wrinkled paper. I really can't appreciate the wrinkled paper, but okay, I'm willing to appreciate that this can't be anything else but a Gaucher cell. And here is what a Gaucher cell looks like in high power. This actually looks like a face again by chance. Trephine was not performed, and our diagnosis was Gaucher's disease. The differential is Niemann-Pick disease, which has bubbly cells rather than this wrinkled paper appearance, pseudo-Gaucher cells, and Mycobacterium avium intracellular. Biochemically, we proved that it was Gaucher's disease. And just some gyan for you, it's an autosomal recessive disorder which has a deficiency of beta-glucosidase, and the Gaucher cells contain glucocerebrosidase deposition. Now, as pathologists, we tend to make a diagnosis and leave it at that and don't think of anything else. So I have got some information out here for you guys, which would not be of immediate importance to you as pathologists, but, well, you need to learn something. The first thing is, all of us Indians call it Gaucher's disease, but that's wrong, because Gaucher suggests that it's a German name, but this was described by a French physician, Gaucher, pronounced Gaucher, and that's why it's Gaucher's disease. All of us know that it's seen in kids, but I was surprised to learn that sometimes it is even diagnosed in adults. So it can go through our entire childhood and adolescence and be diagnosed with Gaucher's at the age of 40. There are 3 types of Gaucher's, and I was also surprised to learn that there is something called the Gaucher Disease Task Force in India, which looks into this, although it's a rare disease. How rare is it? We know it's the most common lysosomal storage disorder and forms 46% of cases of the lysosomal storage disorder center, disease at the rare disease center in Jaipur, yet it's rare. KEM Bombay had 37 cases in 16 years and CMC Vellore had 60 cases in 15 years. So it's really rare. This is an important thing. Gaucher's disease no longer has a role for aspirator biopsy in making the diagnosis because the glucocerebrosidase assay is diagnostic. So it is quite likely that you guys will go through your lives without ever seeing a Gaucher cell in your practice. The other thing is splenectomy may worsen, in fact, will worsen skeletal and lung issues. And so the Gaucher task force recommends that do not perform a splenectomy in a patient for a diagnosis. If there is the slightest possibility that this patient might have Gaucher's disease, go ahead and do a biochemical analysis. Do not perform a splenectomy. You will be killing this person. We now have enzyme replacement therapy in India, which is not cheap. It costs from 40 lakhs to 70 lakhs per year. It was first done in India in 1999. Okay, the next one is a 71-year-old chappie with Hodgkin's post-chemotherapy. He had a PET CT showed diffuse bone marrow, FDG uptake, aspirate was normal, and he landed up in our hospital. Aspirate was normal elsewhere, he landed up in our hospital, and because of a hemoglobin and platelet like this, the bone marrow biopsy was repeated, and this is what the aspirate shows. And obviously, you can't see any hematopoietic cells out here, but you can see some pinkish purple stuff. Again, a few hematopoietic cells in this. They look like mononuclear cells. Again, yes, lymphocytes and plasma cells in this granular kind of purplish material. Again, more purple material and no hematopoietic cells. More of the same. And a trephine shows no hematopoietic cells, but something going on all right. It's a busy marrow, all right. And yes, there's more of this. And in this, you can see some of those mononuclear cells that I had shown you in the aspirate. More of the same. Again, mononuclear cells, which are lymphocytes or plasma cells. Yeah, these are lymphocytes and plasma cells. And you don't see myeloid cells or erythroid cells or megakaryocytes. You don't see metastatic cancer. You don't see Hodgkin's in this. And an Alcian blue stain stains this material blue and gives us the diagnosis of gelatinous transformation of the bone marrow, in which you get metachromatic gelatinous material on the aspirate. And on the trephine, you find Alcian blue positive matrix with very few residual hematopoietic cells and no fat. You can't miss this for a bone marrow necrosis, which arises in the differential, because you expect to find carrier excess in a necrosis. You can't miss it for amyloidosis because you get tons of plasma cells in amyloidosis, and you'd also expect to find the Congo red showing positivity in amyloid. If it were to be a bone marrow edema, it would be Alcian blue negative and fat would be present. And if it were an aplastic anemia, again, you'd see lots of fat. So this is clearly gelatinous transformation only. And it's very uncommon, only 0.19% of cases in a large German study. And patients, this is a cause caused by anorexia, malnutrition, cachexia, HIV, and neoplasms such as Hodgkin's. It's seen only in protein energy malnutrition, not in specific protein deficiencies. Jayashree, you'll have to tell me if I overshoot time. Okay. So the next case is a 35-year-old woman with easy fatigability, epistaxis, anemia, thrombocytopenia, and the smear shows an occasional NRBC. And this looks like a hypocellular marrow, I guess. I don't see too much. Oh, okay. Yes. We see cells out here which are clearly not hematopoietic. There's abundant cytoplasm and vesicular nuclei. And these look like epithelial cells, which is confirmed by the fact that they are clustering, unlike hematopoietic cells. Again, clustering of these cells, which tells you that you are looking at probably a carcinoma. Trephine showed it to be packed with these cells. And here are obviously epithelial cells, which have a kind of an India-file appearance out here. And you don't see, well, very, very few hematopoietic cells. Again, very clearly epithelial cells, a carcinoma, groups of cells out here. And we made a diagnosis of metastatic carcinoma, probably breast primary. And after we informed the bone marrow report, the physician went back and learned that the patient had a right breast lump for 2 weeks with retraction of nipple, and a CT showed nodes, liver, spleen, and widespread bony metastasis. So immunohistochemistry is spectacular in making a diagnosis of an unknown primary, but there's no law against good clinical examination and using your common sense in making a diagnosis. Well, here, for instance, a bone marrow with abundant mucin, lots of mucin and glands, and this was a colloid carcinoma of the rectum. But in another part of the universe, so to say, And I'm grateful to Dr. Swati and Vishut from Manipal Hospital for sharing this case which they had last week. A 17-year-old boy with pancytopenia and what looks like, well, like the previous breast case. You can see cords of cells, what look like India file. Again, you can find India file pattern of cells. You can find a huge group of cells out here. Nesting pattern looks like carcinoma, but every cytokeratin was negative. And so they had a rethink and they discussed it with the clinician and then did a NKX 2.2, which is strongly positive, and a CD99, which is positive, strongly positive again. And this was a case of Ewing sarcoma. And of course, there is the question, in a 17-year-old boy, you wouldn't expect a metastatic carcinoma. If you aren't careful, you'll call this a normal bone marrow, and you wouldn't have paid attention to these small areas out here, which on high power are very clearly malignant round cell. This was a metastatic medulloblastoma. So when you look at a bone marrow, be careful not to mistake metastatic neuroblastoma or round cell tumors, which are hiding amidst normal hematopoietic cells, single tumor cells amidst collagenized stroma. Don't mistake them for a Hodgkin's or an ALCL or a plasmablastic myeloma, the last of which I have seen and had a problem with. And like I said, a CA breast, you have to do immunostains before calling it normal. Okay, here's a 58-year-old woman with chronic liver disease with splenomegaly and loss of weight. And these are her counts. She has a liver and spleen and looks like a fairly normal aspirate. That's a megakaryocyte. But on trephine, while this is normal, here is something which is abnormal. Here is a small group of cells which is abnormal. And on high power, you can see that this is a lymphoid nodule. And you can see there's an irregular lymphoid nodule. There are no germinal centers. Well, this is one, and here is a second one. We don't know if there are more than 3 or not, if you remember what I told you in the introductory part of this talk. But certainly, no germinal center, irregular margin tells you that this may be neoplastic, but we call it a lymphoid nodule, need to rule out NHL. And when we did a CD20, almost all of the cells lit up for CD20, and we made a diagnosis of a low-grade lymphoma, a splenic marginal zone lymphoma. But the aspirate was normal because it had not picked up cells from that area. So always look carefully for lymphoid infiltrates, especially in splenomegaly, even if the patient has had chronic liver disease. There's nothing to prevent the patient from having 2 diseases at the same time. Chronic liver disease followed by a low-grade lymphoma. Okay, I'm coming towards the end, I think. This is a 60-year-old man who had a supraclavicular and left axillary node, which was biopsied and opined on. I won't tell you what the opinion was, but the aspirate was, hey, pretty normal. But the trephine is obviously not normal, and it is packed with something. And looks like a mononuclear kind of a thing out here. Again, it's packed with these cells. I call it that because that's all I can say this. And here I can see that many of them are lymphocytes. But what is interesting is tons and tons of these cells are eosinophils. And now I'll tell you, the story was this patient was diagnosed as having a Hodgkin's. So he had a Hodgkin lymphoma, and a bone marrow was done to see whether he had bone marrow involvement or not. And there are many eosinophils out here. Maybe something out here. And yes, certainly when you look at serials, when you look at other sections, you can see in fact, this is a binucleate cell. And this is clearly a Hodgkin involving the bone marrow. Now, we did do a reticulin because we are told to do a reticulin in 100% of the cases. And we found, to our surprise, that reticulin was markedly increased, which we had not expected on the HND. Now, I don't know honestly whether this would change the management of this patient in any way because he's got bone marrow involved anyway. It's an important thing. The reason I've kept this reticulin out here is to show you guys that even when you don't suspect it on HND, you might get lots and lots of reticulin. So this is a classic Hodgkin lymphoma. So the bone marrow aspirate may not help, and the trephine is more useful, especially when you get eosinophils or Reed-Sternberg cells. When you see just fibrosis, you might call it suspicious involvement. And what does that mean to the physician? Nothing. Suspicious is neither here nor there. He needs to know whether there is disease or not. And I'm grateful to Dr. Jayashree and Sudipto for sharing this case with me, where they have this patient with Hodgkin's with a lot of fibrosis in the bone marrow, but apparently no RS or mononuclear cells. But when they did a CD30, there were some cells which stained positive, and a CD15 stained more cells. Here's one more. So CD15 and CD30 positive in a patient with a fibrotic marrow when he has Hodgkin is consistent with the diagnosis of bone marrow involvement. But you do not classify the subtype of Hodgkin on the marrow, do remember. And 1 to 10% of Hodgkin marrows, 1 to 10% of marrows are involved in Hodgkin disease. And HIV positive cases are more likely to be involved. This is the last one, I think. A 55-year-old man with a spleen, a leukoerythroblastic reaction, occasional blasts. And if you look at the aspirate, it's less cellular than usual. Again, very few cells in the bone marrow aspirate. Very few cells again. And whatever cells you're seeing which are hematopoietic are absolutely normal. These are erythroid cells that you can see, and these are myeloid series cells. And when you look at the trephine, you can see some hematopoietic cells out here, some again out here, but not over most of it. What can you see? You can see some kind of what may be fibrosis. Again, some hematopoietic cells. Here are dilated sinusoids, which is very important for this. You can see some kind of streaming pattern out here, and yes, this does look like fibrosis. You can see prominent osteoblastic rimming in this marrow. Again, osteoblastic rimming, a dilated sinusoid, and the reticulum shows at least grade 2 to perhaps grade 3 fibrosis, and this was a case of myelofibrosis. But a potential pitfall when you see this is, here's a marrow which shows again these prominent osteoblasts. You can see some kind of fibrosis out here. In fact, fair amount of fibrosis. The same, pretty much the same again. And if you are in love with your diagnosis of myelofibrosis, okay, here's the same thing. If you're in love with the diagnosis of myelofibrosis, you will miss the fact that there is a metastatic adenocarcinoma in the same bone marrow. So that fibrosis was because of the metastatic adenocarcinoma. That was not myelofibrosis. The last two slides, you can sometimes get an increase in the amount of bone per unit volume of tissue in METs, like I showed you a case in the very beginning, or in fluorosis of Paget's disease. And this was a case where a bone marrow biopsy was done and we made a diagnosis of Paget's disease. And what you can see is irregular cement lines in the bone marrow. I must admit, I saw this many, many years ago, and I remember very little of it. But the fact is, when I saw it then, I was able to make a diagnosis. And if you see a vastly thickened trabecula, you have to think of other diagnoses. So this was our diagnosis, that myelofibrosis or osteosclerosis, and in one of them, look for adenocarcinoma. And that is my hospital, and I've taken up, I think, 40 minutes or so. Thank you.
Okay. Now, Dr. Sanjay Pai has shown us almost majority were non-neoplastic, I think, except Hodgkin's. So I thought I will take you through a few of the common and some rare neoplastic conditions. So case number 1 was a 30-year-old female with weight loss, tiredness, and lymphadenopathy. So even as a PG and even now when I practice, I am very excited when I see a leukemia. So this patient had a high total count of 30,000 and anemia and thrombocytopenia and slightly elevated LDH. 30,000 total count. Predominantly, they were all lymphoid cells, as you can see even at this far in the peripheral smear. Very thin rim of cytoplasm, inconspicuous nucleoli or occasional prominent nucleolus, but you can see the cytoplasm which is showing a hand mirror-like appearance. The bone marrow of the same patient, hypercellular marrow, completely replacing the normal hematopoietic tissue by these sheets of blasts, which are slightly varying in size, medium to larger cells, and thin rim of cytoplasm, blue cytoplasm, occasionally showing prominent nucleoli, but predominantly inconspicuous. And this cytoplasmic hand mirror type of appearance is very prominent here. This is a past stain of the same, and you can see that there is block positivity in these cells. So as I was telling you in the introductory session, MPO and PAS are two stains which can help you very much in the giving the preliminary diagnosis. And this is a bone marrow biopsy of the same patient with hypercellular marrow, hardly any fat spaces. At a higher par, you can see that the bone marrow is almost replacing the normal hematopoietic tissue except for these few probably megakaryocytes at this par, and there is lot of necrosis in the bone marrow. Now with this, the preliminary diagnosis of acute leukemia, which was morphologically as well as cytochemically looking like a acute lymphoid leukemia, lymphoblastic leukemia. Of course, without the cytochemistry, we would have a differential diagnosis of AML M0, which can really sometimes create trouble, or NHL spillover if they were much more larger with more nucleoli, or regenerating marrow with hematogones. Hematogones can really confuse you sometimes. So the I was done and they were CD10 and CD20 positive. So 20 is a B cell marker and TDT was negative, but CD99 was positive. So this proves to say that it was a lymphoblast, and the flow cytometry was positive for markers of 19, 10, 34 HLA-DR, Cyto79A and TDT, whereas the T markers and the myeloid markers were negative. So DIM45, CD45 is very classical for ALL, especially B-ALL, and CD79A is a lineage marker. Myeloid markers are absent. Color positive, it is spurred. If it is CD10 positive, it carries a better prognosis. And CD34 and TDT, that they will differentiate between the acute lymphoblastic leukemia from the NHL, because NHL predominantly is a mature cell, so the immaturity markers will be negative. What is important here is to differentiate these. In our case, there were sheets of blasts, but sometimes in a regenerating marrow, you can find similar cells which have a very thin rim of cytoplasm, loose cells, and you might get confused with hematogones. So for which the flow cytometry will help in differentiating. They have a pattern of expression from the type 1, type 2 and type 3 cells, and CD34 less than, TDT less than 20 and PAX5. And the CD10-20 dot plot is very characteristic, J-shaped trail pattern will be seen. So the final diagnosis in this case was increased blasts in the peripheral smear with typical L1, L2, the hand mirror type of morphology, and cytochemistry showed the block positivity, very classic slide. This is a pre-B-ALL Kala positive. Coming to case number 2, 3-year-old male. Now age is important. Fever 3 to 4 days, irritable, arthralgia. Typically children coming with arthralgia and fever, you have to be very careful. Do not get confused and or neglected thinking it is a viral, because picking up these abnormal cells on the peripheral smear is very important. Bilateral lymphadenopathy was there. On the CBC, there were not much the counts looked okay, but there was thrombocytopenia, and look at the LDH. It was very high, 4038 units. On the peripheral smear, we didn't have many abnormal cells. However, in view, you could see a normoblast. This is very useful for me when you think of a marrow infiltrative disorder. Even though you do not see any abnormal cells, in case you see normoblasts in the peripheral smear, that means there is, and provided there is no hemolysis, there is something in the marrow which is pushing these cells to the periphery. Okay, but when we did the bone marrow was filled with these large atypical lymphoid cells which had hyperbasophilic cytoplasm, and you can see the cytoplasmic vacuoles. These cytoplasmic vacuoles on PAS stain showed block positivity again. This is very useful. On the bone marrow biopsy, It is a hypercellular marrow showing predominantly lymphoid population, lymphoid blasts. From here you can make out they look like quite lymphoid, though it may be very difficult to differentiate myeloid or lymphoid in the biopsy. But you can see that there is lot of apoptosis in the background, something which is telling you that there is lot of proliferation that is happening. If you do a Ki65 in this, definitely it will be more than 90%. So our diagnosis from the morphology of the blasts in the bone marrow as well as the PAS, we could call it a ALL, L3 or the Burkitt's leukemia. Now in this patient, this has to be differentiated from other round blue cell tumors. And in adults, if the similar morphology, you have to exclude DLBCL, lymphoblastic leukemia or the plastic mantle cell leukemia. Flow will show a bright CD45, surface kappa or lambda light chain restriction. And since it is a mature B cell neoplasm, CD34 and TDT will be negative. The chromosomal analysis in this case showed 814 translocation, which is very classical for Burkitt's leukemia. So this case, in the peripheral smear, though we did not have any abnormal atypical lymphoid cells to call it a Burkitt's, the presence of those NRBCs in the marrow and the typical history of a 3-year-old child with fever, arthralgias should make you think if there is anything in the bone marrow, and you have to rule out a leukemic process. Coming to case number 3, 66-year-old male, no fatigue, not many symptoms actually. There's no lymphadenopathy or splenomegaly. But in the routine investigations, this patient had a total count of 64,000 with 66% lymphocytes. On the peripheral smear, the count is increased. You can see that predominantly they are almost the size of the RBC. So they are the mature lymphocytes, and you see a lot of these smudge cells in the background. So as soon as you see this picture, the football type of chromatin, small mature lymphocytes and smudge cells in the periphery, you think of a chronic lymphoproliferative disease, most likely a CLL. Yeah, this is from the bone marrow. You see the megakaryocyte here, and bone marrow also has increased mature B cells with a similar morphology which we saw in the peripheral blood. The normal hematopoietic tissue is markedly suppressed. The biopsy is quite cellular, predominantly showing these monotonous cells. And here you can see that vague nodule which Dr. Sanjay was telling about. Whenever you see a nodule of lymphoid cells, you need to be aware that you might be dealing with a neoplastic process. And bone marrow biopsy was suggestive also of a chronic lymphoproliferative disorder, correlating with the peripheral smear and bone marrow aspirate, possibly a chronic lymphocytic leukemia. Now, in this case, the flow was done and flow showed CD5, CD23 positive. So it's a B19 positive tumor actually, and gating on the 19 positive cells showed CD5 and 23 positive. So which is very classical of CLL. And if 23 is negative, you think of mantle. CD20, CD200 is positive, but here in this case FMC was 7 was positive. Usually in typical CLS, FMC will be negative. In this case, it was positive, so maybe it was an atypical CLL. And this was negative for CD10, so you are ruling out your Germania center, that is DLBCL, follicular and Burkitt's. CD25, 103, you are ruling out your hairy cell disease. Okay, and it showed a kappa restriction. Cytogenetics was normal. However, what is important is now we do not stop at conventional cytogenetics. Whenever you think of CLL, you have to send for FISH panel, which showed positive for non-allelic deletion of chromosome 13q14. So this is important in the staging as well as prognosis. So final diagnosis in this case was a CLL. Case number 4, 38-year-old male workup for lymphocytosis again. Normal hemoglobin, mildly elevated total count, and again 95% lymphoid cells. Platelets were reduced. Now in the peripheral smear, again you are seeing these lymphocytes. When you go to oil immersion, you see that these show a frayed cytoplasm. Some places you can appreciate the hairy processes. Here again, there are a lot of hairy processes. So this is a bone marrow aspirate. Usually in a hairy cell leukemia, you get a dry tap. And however, in the aspirate also, these cells were seen. Some of them really showing prominent hairy processes. So morphologically thought of hairy cell leukemia. The bone marrow biopsy was showing typical fried egg appearance. So these are all the lymphoid cells, hairy cells with a clearing around them. So this is a case of hairy cell leukemia. Now the marrow is filled with mainly hairy cells with abundant cytoplasm and hairy projection. The immunohistochemical stain will be DBA, which will be positive. Another important feature which we saw here was the extravasation of the RBCs. Now, because hairy cell leukemia has a marrow fibrosis, there will be extravasation of these RBCs. That is also another important finding. On flow cytometry, it was not done in this case. However, the hairy cell markers was positive, that is CD25, 103 and 11C. The next case is a 67-year-old female, fever for 1 day only, and 1 week back. She had fatigue, nothing much, pallor was there, there were no lymph nodes. But when we got the labs done outside, the hemoglobin was low, total count was low, and ESR was high. There were a good number of macrocytes seen on the peripheral smear. This is the peripheral smear picture. Though they called it normal, no abnormal cells seen on the peripheral smear, we do appreciate some larger atypical cells here with high NC ratio, and one of them showing a prominent orb. When the bone marrow was done, it was hypercellular, plenty of blasts here. Looking at the blast morphology, you can see there are some buttock-like cells, prominent nucleoli, some nuclear indentation, and Sudan black was positive. Hypercellular marrow on the biopsy also. The marrow hematopoietic tissue is completely replaced by these blasts, and these blasts show multiple prominent nucleoli, which we did not see in the ALL. So this was a case of MPO positive AML. Sometimes the morphology can be really deceiving. So you see buttock cells, you think of APML, but actually it is not APML. And how do you decide that? You do a flow cytometry and look at the markers. So this is HLA-DR and CD117 34 positive. Okay, we'll see in the next case how APML presents, but this is a myeloid neoplasm. So you call it HLA-DR, CD34 and 117 positive AML. Cytogenetics was done and it showed trisomy 8. So this was a case of acute myeloid leukemia with trisomy 8. So whenever you are seeing a peripheral smear with pancytopenia, looking at the history, vague history of fever, fatigue. So think and look for abnormal cells. Do not miss those few abnormal cells which can help the diagnosis of acute leukemia. The next case is a 31-year-old male with bleeding gums. Very important history. And this was after a dental treatment. So patient was advised not to worry about the bleeding and it would subside spontaneously. Patient had pallor and petechial rashes, pancytopenia. Again, there is one atypical cell on the smear. But when you look at the marrow, it is quite evident that these are abnormal granular myeloid blasts. Yeah, they're quite granular, and if you can see, this is what a typical faggot cell looks like, multiple OR rods. In Sudan black staining, it stains positive. So all those are the abnormal promyelocytes with high granularity and faggot cells. Bone marrow is also hypercellular. You can see that pinkish hue, so that itself tells you are looking at abnormal promyelocytes. Even higher power, you can see those granules even in the HND very clearly, and the buttock-like nuclei. Yeah. So this is a classical case of acute promyelocytic leukemia. This needs confirmation by immunophenotyping, but your differential diagnosis without the granules or phagoid cells will still be M2, or sometimes because of the nuclear morphology, you really find it difficult to differentiate from monocytic differentiation. So cytogenetics, typical translocation between 15-17, and the flow showed CD34 and HLA-D are negative. So this was what I was telling you, that flow will help us differentiate between these morphologically similar looking acute myeloid leukemias. 34 and DR is typically negative in APMS. And there is another differential diagnosis with flow of this pattern, that is an NPM1 mutation. So we need to look at the copy number also of the, this is for the follow-up of the patients. PML Clara copy number is done. And this is a case of acute promyelocytic leukemia, hypergranular variant. And that is why it presented with pancytopenia. The hypogranular variant typically has a very high count and easy to pick up. Whatever it is, this is a medical emergency because they need to decide to give ATRA. So as soon as you see a APM, you have to inform your clinician about it. Okay. Coming to the next case, easy fatigability. I don't know why the age is not mentioned here. Headache on and off, and query blast cell on the peripheral smear in an outside lab. And they said blast around 43%. So here again, you are seeing some abnormal but myeloid looking cells. If you go to higher power, you see that they have some cleaving of the nuclei. Granularity is present. There is a myeloid blast there. Bone marrow aspirate, definitely increased blasts of varying size and shapes. Some of them are showing the cytoplasmic vacuoles here. Cytoplasmic vacuoles, convoluted nuclei, an OR rod here. Similar picture. But you know, you are seeing some vacuolations. There is an OR rod here. So there are myeloid blasts and there are monoblasts and promocytes. So this is an AML with monocytic differentiation. Again, a closer DD will be acute promyelocytic, the hypogranular variant. You have to rule out M2, and sometimes there may be dysplasia wherein you should consider a possibility of CMML also. But in this case, FISH was done and it was negative for PML RARA, that is APML was ruled out, and on bone flow cytometry, there were myeloid markers as well as monocytic markers. 1464 HLA-DR, very strong expression in monocytic population. So this was a case of AML with monocytic differentiation. The next case is 68-year-old male, easy fatigability and shortness of breath, mild backache, reduced appetite. So pallor was present and spleen was not palpable, low hemoglobin, low total count, low platelets, ESR was very high, B12 was 164. So it was reduced B12, but LDH was mildly increased. On the peripheral smear, not much, but some normoblast here and there, that too not a nucleated RBC or a late normoblast, but a pro-normoblast. When the bone marrow was done, what we saw was there was a lot of erythroid hyperplasia, and you can see these abnormal pro-normoblasts with binucleation. Here again, binucleation, there is nuclear irregularity. Then predominantly, more than almost 80% of the cells are erythroid lineage. A trinucleate here, binucleate pronormoblast, definitely abnormal morphology. Bone marrow biopsy is very, very hypercellular. You can see that though there are, the marrow shows immature cells, there is intermingling erythroid cells. Usually when it is a myeloid leukemia, you just get suppressed, but here the myeloid blast, the blast immature cells and the late normoblasts, they are mixed together. So I was telling you in the introductory session also, usually these erythroid cells keep the company. So that also gives you a clue to say that these are erythroid blasts, pro-normoblasts. Sorry. If you see these pro-normoblasts, they usually have these megaloblasts have a elongated linear nucleoli. That also helps to differentiate between the myeloblasts and the megaloblasts. More higher power view of the same. So this was a hypercellular marrow with the bulk of the marrow space occupied by blasts with myeloid and erythroid morphology. Definitely erythroid was much more than 80% was erythroid, and out of which more than 30% were pro-normoblasts. However, looking at the low vitamin B12 and looking at this picture, we should not attribute it to only megaloblastic anemia due to B12 deficiency, or even sometimes in alcoholism you get a similar picture. You should think beyond that and suggest a possibility of M6 looking at the morphology. The other differentials are pro-normoblasts, like what Dr. Sanjay already showed us, the parvovirus. A megakaryocytic leukemia can also look similar, but cytoplasmic budding will help us, and it will be positive for CD4161 by flow. Then in this case, the flow was done and it revealed 12% myeloid blasts, but the CD45 negative events. So normoblasts are, the erythroid cells are CD45 negative. They constituted 50% of those population, and they were positive for 41 and 61. So this confirmed the diagnosis of AML M6. And on cytogenetics, it showed multiple anomalies, and it was consistent with AML with a complex karyotype. So please do not forget to rule out B12 deficiency, alcoholism, and autoimmune before calling it M6. However, do not suggest the possibility of M6, right? Case number 9, 35-year-old male evaluated for redness in the right foot and detected to have a high hemoglobin value and had headaches. A very classical history, conjunctival suffusion. So everything points out to say that his red cell mass is increased, and aquagenic pruritus is a very typical history which you get in such cases. When you look at the labs, hemoglobin is 22.3, uric acid is increased, whereas the EPO was reduced. So straightforward case. It was a case of, okay, let us look at the all the details. So this smear itself, you can see this is a normal smear with, say, a hemoglobin of 12 or 13, 14, whereas this is definitely much thicker smear. And on the smear, it showed a normocytic normochromic blood picture, but bone marrow aspirate showed this erythroid hyperplasia with lot of pro-normoblasts. Now, when you look at the erythroid series in a normal marrow, so the pro-normoblasts will be minimum in number compared to the intermediate and the late normoblasts. Whereas here, in any neoplastic process, you see that the pro-normoblasts will be increased. The marrow is quite hypercellular, and what you also can see is there is increase in megakaryocytes also. Now, when it comes to MPNs, whether it is polycythemia or CML or ET or your myelofibrosis, all the 3 cell lines can be proliferated in different proportions. But the megakaryocyte morphology will help us differentiate between the different types of myeloproliferative neoplasms. For example, in this case, as we have already by now everybody knows has got the diagnosis of polycythemia vera, you can see that these megakaryocytes range from small to medium to large size. They can be in small clusters, not dense clusters, what you see in myelofibrosis, but you don't see that bizarre type of nuclei. Okay, so see, they are quite benign. Some look like staghorn nuclei. So this is a case of polycythemia vera. So your major criteria will be elevated hemoglobin and bone marrow showing hypercellularity with trilineage growth, panmyelosis. But you have to prove the presence of JAK2 mutation. And minor criterion will be your erythropoietin level, which will be reduced. Now, this is a nice chart given in the WHO book, which tells you how to differentiate between the myeloproliferative neoplasms based on the cellularity and the granulopoiesis, erythropoiesis, which is more in polycythemia vera. When it comes to megakaryocyte, the size of the cells, how it forms clusters and the nuclear features, you can say whether it is in ET, where the size is much larger and giant forms are seen and hyperlocation is seen with staghorn forms in both PV and ET. But when it comes to myelofibrosis, there are too many clusters and they are dense clusters. So these features will help you differentiate between the three. And of course, fibrosis will be more in the overt form of the primary myelofibrosis. It doesn't end here. You will have to do the mutation analysis. So JAK2, then MPL and CALR mutation, which will differentiate between the three cases. So this case was a JAK2 positive polycythemia vera. And what we saw in the history as well as in the labs, that uric acid was increased. So this was a case of polycythemia with gout. Next case is a 70-year-old known case of CKD on dialysis and presented with cytopenia. Now, hemoglobin is 8, monocytosis is present. Platelet count is again low. Rest of them are not really contributory. Now, if you look at the peripheral smear, you can already make out that there is monocytosis. Closer view, monocytosis, but are these the regular monocytes? Do not look like regular monocytes. There is nuclear abnormality in the lobation. You don't see much of cytoplasmic vacuoles. They are showing some granules. So these look like abnormal monocytes. Yeah, not much shift to left. In the bone marrow, again, you see some cytoplasmic vacuolations and predominantly the monocytoid series, but really cannot appreciate many blasts here. So on the differential count, you look at the lacy chromatin of the promonocytes and monoblasts. It's not as dense as the myeloid. The other series also showed dysplasia. So the erythroid cells showing so many nuclear fragments, binucleate erythroid cells, very irregular shaped nucleus. The myeloid is also showing nuclear abnormality. On the bone marrow biopsy, see the hypolobated megakaryocytes, and it is quite a hypercellular marrow, predominantly myeloid and monocytoid. If you see, you can appreciate these monocytoid cells, many monocytoid cells. Yeah, so you are seeing monocytosis, you are seeing dysplasia. So when you see such a marrow, and if your blast count, blast here comprise of both promonocytes and monoblasts, you have to consider for blast count. If it is less than 20%, then probably you are looking at a case of CMML. So that is a MDS MPN syndrome. Here, differential diagnosis will be, you have to rule out the reactive monocytosis, which will not show so much dysplasia. Yeah? And other MPNs with monocytosis. You can have the other myeloproliferative disease, especially like CML also can show monocytosis. So you have to consider everything and then decide if it is a CML. Now, you have to rule out CML. So it is negative for BCR-ABL translocation. So this was a case of monocytosis with trilineage dysplasia, MPS MDN category, the CMML 1, because the blast count is less. So this is the WHO classification with the criteria you need to say that it is a CMML, because you have to rule out all the other causes of myeloproliferative, that is your CML, your node rearrangement for PDGFRA, B and FGFR1 PCM and JAK2 mutations. Blast count should be less than 20%, and there should be dysplasia involving one or more of the myeloid lineage. So as soon as you see your monocytosis, look for dysplasia. See if you're seeing only a reactive monocytosis, as you could see in a malignancy or infection or inflammation. All these need to be ruled out before you can label it as CMML. Okay. Now coming to the next case. This is a 72-year-old male, easy fatigability. So old age, body pains, vague symptoms, pallor is present, no spleen or lymph node. Cytopenias, all the counts are reduced. B12 is also low, please note. Cytopenias, so not many cells on the peripheral smear to comment, but you can make out some macrocytosis. And if you look at the nuclear morphology, looks dysplastic again. So erythroid with lot of nuclear abnormality. Myeloid also, the granules, I am not happy with the granules. Nuclear morphology again showing dysplasia. A binucleate erythroid cell. Megaloblastic change, hypogranularity, nuclear abnormality, hypogranularity. A normoblast with a Howell Jolly body. Look at this. Very abnormal nuclear morphology. You could also get ring neutrophils. So megaloblastic picture. See this. So much of nuclear fragmentation, a binucleate normoblast, lot of dysplasia. Coming to the megakaryocytes, multinucleation, hypolobated megakaryocytes, binucleate megakaryocytes, pearl stain showing ring Cydroplasts. A bone marrow biopsy, not very hypercellular, a lot of blood, probably traumatic damage there. But here you can see clusters of immature cells, definitely. Yeah. You can see that shift to left. You don't see any mature myeloid series. Yeah, cluster of immature cells. These will be your erythroid. Even here you can appreciate that binucleate population, mitotically active. So you will have a differential diagnosis. A severe megaloblastic anemia, you can have a lot of dysplasia, HIV, recent cytotoxic therapy, alcoholism, intercurrent infections, autoimmune. Autoimmune is one more thing you need to rule out whenever you see so much of dysplasia, PNH, congenital dyserythropoietic anemia. So there is erythroid hyperplasia, megaloblastic maturation, erythroid series seen in paratrabecular locations. Megakaryocytes are decreased in numbers. Yeah, we really didn't appreciate many megakaryocytes. But if you do the CD61, you can appreciate because many of them will be hypolobated megakaryocytes. This is a MPO showing lot of collection of, myeloid cells. CD71 again, CD34. So the blast, as you expected, you saw so many immature cells, but CD34 is not so much increased. Yeah, this is CD117. It can stain little more mature cells. So this bone marrow was sent for IHC, and they reported that there are approximately 40% and 15% of CD79, 117 and CD34 cells. So they called it a high-grade MDS. So macronormoblastic maturation, erythroid in paratrabecular, Hematopoiesis expanded, no ellipse. 61 highlights the micromegakaryocytes, and there are increased blasts, but not more than 20%. So when we got the cytogenetics report, usually that takes much longer time. By this time, we are only thinking of MDS. But when we really got the cytogenetics report, we got to know that the patient also had inversion 3. And inversion 3 is consistent with AML. Okay. So this was up to my IHC stage. You could call it a MDS, but when you got the cytogenetics report, it was a AML with recurrent genetic abnormalities in inversion 3. So what I'm trying to say is you do not stop at aspirate or biopsy or some special stains. Every case has to be, especially when there is a possibility of a hematological malignancy, you have to go ahead, send for cytogenetics, and if required, ISC should be done. And this patient actually had a B12 deficiency, but do not neglect that and say you want to wait. Just follow up, talk to your clinician. Maybe he has an underlying MDS. Case number 12. So this is a 71-year-old incidentally detected high ESR. It was 69 and they started working up for that. Apparently the serum protein electrophoresis showed M band, IgM kappa, monoclonal gammopathy. And the free light chain assay showed was also increased. There was on X-ray collapsed L1 vertebra. So on the peripheral smear, you are seeing these lymphoid cells. So bone marrow was also done. Again, in the bone marrow, you are seeing these predominantly lymphoid cells in the background. These are your normoblasts, but there is one plasma cell here. Again, predominantly lymphoid, but there are some with more abundant cytoplasm. More abundant cytoplasm here. Yeah. Some eccentrically placed nuclei, some plasma cells. So we are looking at a different kinds of population. You are seeing lymphoid cells, you are seeing plasma cells, and you are seeing lymphoplasmacytic lymphocytes. Yeah. So on the bone marrow biopsy, hypercellular, and not much we can appreciate from this biopsy. So this preliminary diagnosis of lymphoplasmacytic lymphoma was given. We will definitely have to rule out the other CLPDs which look similar, CLL, but you don't get plasma cells in that. Splenic marginal zone lymphoma, yeah, can appear, but they have some cytoplasmic fraying, and mantle cell lymphoma, which have cleaved nuclei. So on bone marrow, on the flow, CD19 positive cells were showing CD20, so meaning it is a B lymphocytic neoplasm. CD38 was positive, which is a marker for plasma cells, and these cells were negative for CD5 and CD10. Now, as soon as we say CD5 negative, so your CLL gets ruled out, and CD10 you rule out your germinal center, that is follicular cell, DLPCL, and your Burkitt's, right? Here cytogenetics was normal. So a confirmatory test for LPL is MYD88 L265P mutation. This is positive in more than 90% of the cases. So for the final diagnosis was lymphoplasmacytic lymphoma with IgM kappa gammopathy, the Waldenstrom's macroglobulin. This is quite an indolent disease, but certain factors like age and cytopenias, high protein, high beta-2 microglobulin, deletions, associated deletion 6q, and this MYD mutation are poor prognostic markers. So these are the criteria to call it Waldenstrom's macroglobulinemia. Now, after a lot of neoplastic cases, I thought I'll present one non-neoplastic, very interesting and one which you should not miss. Yeah, this is a 35-year-old male, a febrile episode since 4 days, polyarthralgia, small joints, feet. So again, as you know, febrile and polyarthralgia, think of leukemia to a bone marrow, spleen not palpable, and lymph node also not palpable. Labs looked okay, except that platelet was okay. Initially, platelet was 1,58,000, but subsequently, within no time, the platelet started dropping, and ferritin started increasing. LDH was very high. So, what are we thinking of? We are thinking of HLH, or the hemophagocytic lymphohistiocytic syndrome, or the macrophage activation syndrome. On the peripheral smear, subsequently, this was the peripheral smear picture showing some lymphocytes here, reactive lymphocytes. So was it some viral which was further progressing to decrease in counts, what are we looking at? Yeah, on the bone marrow, some histiocytes here with debris, some histiocytes here which have engulfed the normoblasts. Here there is an eosinophil inside the histiocyte, a neutrophil inside the histiocyte, Rbcs inside the histiocytes. So these are all features of your hemophagocytosis. This is a bone marrow, quite cellular. We really can't appreciate hemophagocytosis on the bone marrow. Preferably, a bone marrow aspirate is better always, but you can make out that there is a histiocyte here. Probably this is a histiocyte which has engulfed some cells. So this was a case of hemophagocytic lymphohistiocytosis. As soon as whenever you see any viral fevers, but persistent fever and the count start dropping, think there must be something more to it. We know that viral fevers have low counts, but if it is deteriorating, a viral fever usually improves over time with or without treatment. But if it is persisting and if it is deteriorating, one thing which you must keep in mind is your hemophagocytic lymphohistiocytosis. And these are the criteria to call it HLH. You have your diagnostic criteria for with fever, splenomegaly, cytopenias, hypertriglyceridemia, hypofibrinogenemia, and hemophagocytosis in the bone marrow. But we had another case wherein initially he presented with pancytopenia, there was HLH. Subsequently, he started developing these, we started seeing in the peripheral smear these cells with large granules. This was nothing but a NK cell lymphoma. So what I'm trying to say is whether it is viral, you might conclude it as a viral, but keep a look at the peripheral smear, look for these abnormal cells. NK cells are known to progress to HLH. So I would like to end my talk with this picture. You can see that this is such a colorful thing and you want to look at each one of them in detail. But in the process, do not forget to focus on what is most important considering your clinical picture, yeah, and make a useful diagnosis for the clinician as well as the patient. Thank you so much. Thank you.